Hello everyone, I am Dr. Rohit Solanki. Welcome in Radio with Rohit. Today we are going to discuss the pineal gland mass. In the sequence, first we will discuss the anatomical location, then we will discuss the differential of the pineal gland mass, then how to report on MRI and CT scan. So let's start our discussion. So this is the normal anatomy of a brain. Here we can see this is a fornix with velum interpositum. This structure is the internal cerebral vein and our tiny structure pineal gland is hiding over here. So there is a mnemonic famous VIP with cranium to caudal direction, fornix, velum interpositum, internal cerebral vein and pineal gland. Here we can see that this is the fornix, this is the velum interpositum, this is the internal cerebral vein. Another intercerebral vein is merging in it and forming the vein of Galen. So this is the habenular commission of the pineal gland, this is the posterior commission of the pineal gland, this is our pineal gland. So here we can see that these two cerebral vein, internal cerebral vein merging together and form the vein of Galen. This is the MRI-T2 with the fornix, intercerebral vein, vein interpositum and our pineal gland. So here is our pineal gland location is here. Now the question is what or which kind of tissues are there in the pineal gland? So 95% of the pineal gland is formed by a specialized type of the neuron called as pineocyte. This pineocyte is having photosensory and a neuroendocrine function. Pineal gland hormone release the melatonin which has two functions, reproductive rhythm and circadian rhythm. So pineal gland maintain our circadian rhythm with the help of the melatonin. So pineal gland masses differentials are divided into the three categories. First, the masses which are originating primarily from the pineal parenchymal tumor, which constitute the 30% of the all the masses. 40% of the masses, or we can say the most of the masses of the pineal gland are arising from the germ cell. So we are defining them as germ cell tumor. Most common among all the germ cell tumor is the Germinoma, which constitutes the two-thirds of the all the masses, while one-third of the masses are non-germinomatous germ cell tumor. Other, like the MEDS and other tumors, constitutes 20 to 30% of the pineal gland mass. So pineal gland masses are divided in the parenchymal tumor, germ cell tumor, and others. So first of all, we will discuss the pineal parenchymal tumor. This pineal parenchymal tumor are divided. First is the pineocytoma. Second is the pineal parenchymal tumor of intermediate differentiation, or we can call it PPTID, and pineoblastoma. This is WHO grade 1, WHO grade 2 to 3 and WHO 4. This WHO grading is based on the mitosis or the aggressiveness of the tumor. So we can say that pineocytoma is least aggressive tumor while the pineoblastoma is the most aggressive tumor of the pineal parenchymal tumor. So question arose, what are the different clinical features will be there if patient come with the feature of the pineal gland tumor? So there will be obstruction in the CSF pathway leads to the hydrocephalus, Parinaud syndrome, pituitary apoplexy in the pineal gland mass. If there is a mass in the pineal gland and there are the multiple masses or mass in the supracellular region, so if pineal mass with the mass in the supracellular region is there, then it is most likely to be Germinoma. If mass is in the pineal and multiple masses are there in the CSF, it could be pineoblastoma, germinoma or the METS. We will discuss it in detail. So first of all, we will see the calcification or the type of the calcification. There too could be two type of the calcification. First is the blastic or peripheral. We can say that peripheral is blastic, and second is engulf or the central engulf calcification. If peripheral calcification is there, and it could be pinealocytoma or the pinealoblastoma. If engulf type of the calcification is there, it could be PPTID and germinoma. So a patient with hydrocephalus, Parinaud syndrome, pituitary apoplexy, pineal gland mass came with the calcification in the periphery. It could be pineocytoma or the pineoblastoma, and the type of the engulf type of the calcification or the central calcification, it could be PPTID or the germinoma. So first of all, we will discuss the pineocytoma. So this a beautiful, well-defined 1 to 3 centimeter of the size mass is called as pineocytoma, which constitutes the 15 to 60% of the primary pineal parenchymal tumor. It is very slow growing and well differentiated tumor of WHO grade 1. So if an adult approx age 40 years come with a very slow growing mass in the pineal, which is showing the peripheral type of the calcification with a well demarcated round to oval margin, we will diagnose it as a pineocytoma. One beautiful characteristic thing is the immunopositivity of the pineocytoma, which is showing immunopositive for the synaptophysin, NSA or the non-specific enolase, and then neurofilament or NFP. So this is about the pineocytoma. This is from the Osborne pathology, 1 to 3 centimeter of the size, well demarcated, round to lobulated, presented adult, mean age approximately 40 years. On CT scan. There will be either mixed iso to hypodense of the mass with calcium exploded, or we can say the peripheral calcification. So mixed to hypodense mass with the peripheral calcification on CT scan, we will differentiate is the pineocytoma. On MR, on T1 weighted image, there is ISO to hypointense, while on T2 weighted image, there is hyperintense imaging will be there. Cyst is common, may it shows the hemorrhage, variable enhancement will be solid, rim or nodular. So this is about the pineocytoma. Let's discuss the CT scan of the pineocytoma. So this is the CT scan of male came a mass in the pineal. So here we can see the cystic mass. So cystic mass is CSF attenuation density with the peripheral calcification over here is well defined, round to oval, small in size, not showing aggression over the mass. So this is most likely pineocytoma. Let's discuss the T2 weighted image of this patient. So this is CSF density with the peripheral hypointense solid mass. So cyst with the surrounding rim of the solid mass is the pineocytoma. Same patient on the flare. Now here the CSF density is somewhat hypointense, while on the flare there is not suppression of the complete fluid, and the cyst wall is hyperintense. So this on flare imaging showing the peripheral hyperintense solid mass with the not proper suppression of the fluid inside the mass. So this is the pineocytoma. On post contrast study of the same patient, cyst wall enhances. Here we can see that this wall is enhancing. So we have discussed the pineocytoma. Another image with a beautiful T2 weightage with solid mass, the cystic areas present pineocytoma, and this is the T1 weighted image. So cyst mass with hyperintense with respect to the CSF. CSF is hypointense while the or mass is somewhat hyperintense. On flare, there is not suppression of the fluid. We can see that CSF is hypointense while our fluid is not hypointense. Heterogeneous enhancement is only post-gale or post-contrast study. So pineocytoma. So next one, our discussion is on the pineal parenchymal tumor of intermediate differentiation. Why we are called as intermediate? Why we are calling as intermediate? So its malignancy lies somewhat in between the pineocytoma and the pineoblastoma. So WHO has put in the grade 2 to 3. A middle-aged male with aggressive type of the mass, which is showing the engulfment of the calcium. If three features, middle-aged male, aggressive heterogeneous, mass lesions, engulfment of the calcium present, then we will discuss the tumor under the pineal parenchymal tumor of intermediate differentiation. So this is table from the Osborne of 50 to 68 of the pineal parenchymal tumors are WHO 2 or 3. Aggressive tumors may disseminate via the CSF. So we have to rule out all the sites where CSF is present to rule out the mates of this tumor. So this is our 57-year-old male with headache, shows the lobulatic mixed to iso or hypointense pineal mass causing the dilatation of the ventricle system or hydrocephalus. The T1 weighted image. Now T2 weighted image of the same patient shows some solid to cystic lobulated mass present over here, which is causing the dilatation of the ventricle system. And this is the post contrast imaging of the same patient. We can see there's the enhancement, strong enhancement of the mass lesion. This is about the PPT ID. The same patient on the T1 weighted image, we can see that the large heterogeneous mass causing the moderate obstructive hydrocephalus. See T2 weighted image of the same patient, iso-intense modulus comprising the mass present over here. And in post contrast, this system wall pathology is showing the enhancement. So this is about the PPTID. Now we will discuss the pineoblastoma. So here we can see that this image, the pineoblastoma is somewhat aggressive tumor which this mass is present in the CSF space in the different places. So we can say that this is the poorly differentiated or aggressive type of the tumor. So WHO grade 4. If we will discuss about the association of this tumor with the retinoblastoma is there, so retinoblastoma 1 gene. If a family has the bilateral retinoblastoma associated with the pineal mass or the pineal gland tumor, then we will call this trilateral retinoblastoma. Look this imaging, the retinoblastoma bilateral with the mass in the pineal gland, so we call this a trilateral retinoblastoma. So usually this pinealoblastoma occurs in the children mainly age below the 20-year with calcium periphery, or we can call it exploit type of the calcium. So WHO grade 4. So poorly differentiated tumor, aggressive tumor with retinoblastoma 1 gene, bilateral retinoblastoma, trilateral retinoblastoma will score if we will have the pineal gland mass association, child less than 20 year at the WHO grade 4. So pineoblastoma, this is a table from the Osborne. So retinoblastoma 1 gene, familial polyposis and dicer 1 germline mutation is associated with the pineoblastoma. Pathology is widespread to CSF and WHO grade 4. All aged was primarily involved in less than 20 years. On CT, there is inhomogeneous hyperdense. So hyperdense, which is inhomogeneous in nature with the calcium exploited or the peripheral type of the calcium. So question is peripheral calcium is there. So peripheral calcification, we have only 2 DD. First is pineocytoma and pineoblastoma. A middle-aged person come with the peripheral calcification, then we have the only 1 DD, that is a pineocytoma. If a child come with the peripheral calcification, so we have the 1 DD, that is a pineoblastoma. So simply we can define peripheral calcification in middle age is pineocytoma, peripheral calcification in the child is a pineoblastoma. On MRI, this is the large, bulky, aggressive looking. Necrosis, intratumoral hemorrhage common. That's why on GRE we can got the blooming. Enhances strongly or heterogeneous on post contrast. WHO, DWI shows the restrictions. Is densely cellular or the hypercellular tumor. CSF we have to look to entire neurotaxis. Look, this is the non-contrast CT of the patient. Here we can see that this large hyperdense mass which is ill-defined, causing the dilatation of the ventricle system or the hydrocephalus. This is WI imaging where we can see that is showing the restrictions. So this is hypercellularity is there. This is the T2 image with the large pineal mass, severe obstructive hydrocephalus in there. This is the post contrast study which is showing the intensely uniform type of the enhancement. Now we will discuss the most common or the 40% of the pineal masses which are come under the germ cell tumor. So germ cell tumor may be the germinoma or the non-germinomatous. 2/3 of the germ cell tumor are come under the germinoma, while the 1/3 come under the non-germinomatous germ cell tumor. Most common among them is teratoma or other non-germinomatous germ cell tumor. So while we discuss what is the intracranial germ cell tumor, this tumor table is from Osborne. It is homologous of the gonadal neoplasm. It has the ectoderm, mesoderm, and the endoderm. Generally affect the child or the young adult. 80 to 90% of the patient come under the age of the less than 20 years. It may secrete the oncoproteins, alpha fetoprotein or beta SCG. So first of all, we will discuss the germinoma. So here we can see this image germinoma, multiple location in the CSF. And so germinoma is pathology. Most commonly it is present in the midline structure. So midline, the pineal is the most common, supracellular is the second most common. Mostly present below the 20 years of the age. And so less than 20-year patient age with engulfed calcium. So we will talking about the germinoma. So if engulfed calcium or the calcium is showing in the center part of the mass lesion, we have only two deities. If it is a middle-aged male, then our deity is PPTID. If it is child or age 20 years, less than 20 years, then it is germinoma. So germinoma on the CT is a hyperdense engulfed pineal calcium. On post contrast, the CT enhances strongly and uniformly. MRI, T1 is hypo to iso-intense and T2 is hyper-intense. GRE, because of the calcium or the hemorrhage, shows the blooming, while on DWI, because of the high vascularity of tumor, shows the restrictions, and CSF spread is common among the germinoma. So let's discuss germinoma on the CT and the MRI. So here we can see that this is the mass hyperdense in nature engulfing the calcium. So this is the calcium over here, which is causing the mild dilatation of the ventricle system. The 90-year-old male come with the history of or the diagnosed case of the germinoma. This is a T1 weighted image of the same patient's well-defined pineal mass present over here. T2 weighted image is a mixed signal intensity with the area of hyper to hypointense. On blooming is present on the GRE sequence. It is indicating toward either the calcification or the hemorrhage inside the mass. This is the contrast. Here we can see there is intensively enhancement in the post contrast study. So now we'll discuss about the non-germinomatous type or the teratoma. The teratoma is divided into the mature teratoma, in which the type of the cell will be the adult type, and the immature teratoma, in which the admixture of the different type of the ecto, meso and endoderm will be there. So this is our the mature teratoma, in which the skin, hair, dermal, CNS tissues will be present. Here different fatty tissues and the calcium and all this will present in mature teratoma. So 8-year-old patient come with the mature teratoma. So on contrast, there will either fat density will be plus calcium plus soft tissue density. It will indicate to the teratoma. So on contrast, the solid mass, calcium and the fat all together constitute the teratoma. On T1 weighted image, heterogeneous intensity mass, which is fat is showing the hyper intense and the soft tissue is showing hypo intense with the different intensity mass present in the gland. On T2, which is also showing the mixed intensity mass. T1 showing the mixed intensity mass with the T1 which called post contrast study, which fat suppressed and lobulated component enlarged enhancement is present. Now, so conclusion of the story: if there is a pineal mass, it is a middle age, or it pineal mass, it is a less than 20-year age. If it is a middle-aged person come with the pineal mass, only two differentials are there. Either it could be pineocytoma or the PPTID. Pineocytoma will have the peripheral calcification, while the PPTID will engulf or have the central type of the calcification. Less than 20-year patient come, then we have the pineoblastoma or the germinoma. If pineoblastoma is there, it shows the peripheral calcification and no oncoprotein will be there. While the germinoma, it will show the engulf type of the calcification, and the SCG and the beta SCG will be alpha protein will be positive, or the oncoprotein will be positive for the. So thank you so much for listening this video. I am Dr. Rohit Solanki, and thank you for watching this video on the radio with Rohit.